I am here to welcome Kathy Ford from Rhinogram and Cameron Cox with MSOC Health. Kathy and Cam.
Thank you, Darcy. It is terrific to be here. Well, thank you for that introduction. I am Kathy Ford. I am the President and the Chief Product Officer here at Rhinogram. Rhinogram is a leading virtual care platform that allows providers and patients to communicate and receive care without any friction whatsoever. And what I mean by that is they can communicate bidirectionally, share images and documents, even have a video phone call or collect payments, and do it all without having to download an app or log into a portal. So your patients don't have to learn anything new whatsoever, which makes it truly frictionless. A little bit about me. I've been in healthcare IT on the commercial side for 27 years now. I've had the privilege to ideate and lead the commercialization of over 100 clinically impactful solutions across 28 countries that are still saving people's lives and improving patient experience and access to care today. I'm most proud of building patient engagement platforms that are in the market today that again increase access and improve the overall experience. I would like to certainly thank Iowa MGMA for this fantastic opportunity to join Cameron and talk about this incredibly relevant and important topic about virtual care. So with that, I'd like to turn it over to my co-panel member, Cameron Cox, who will introduce himself.
The one cool thing about Zoom meetings is this is my role today. I am the Robin to Kathy's Batman. My name is Cameron Cox. I am the president of MSOC Health, which is a Coronis Health company. We work with physician practices, both in the RCM space, strategic management, consulting, various aspects along those lines. I have been in healthcare for just 2 years now because I am 21. I started early. Seriously, I've been in healthcare now. I'll be 50 this year, so it's been a long time, 20-something years. We work with companies, practices all across the country. I've worked with practices as small as 1 up to 100. So it's been a kind of an interesting ride. I look forward to this conversation. Part of my responsibility here too is to bring a little bit of thinking outside the box to this conversation. I will say that I was recently informed right after COVID happened. I had done a presentation on telehealth for rheumatology managers in Florida about 5 years ago. And right after COVID struck, one of the managers emailed me and said, "Didn't you talk to us about telehealth like 5 years ago that we should probably be thinking about this?" So my joke here is that it took $21 billion for us to finally all get EHRs, and it only took a worldwide pandemic for us to finally respect telemedicine. So, let's have some fun with it today.
Terrific. Well, I thought that as we sort of dive into this topic, that it would be helpful to sort of get grounded around a couple things. Maybe to pile on to what you're just saying, Cameron, I really feel like healthcare got caught with her pants down. I mean, it's what happened. Yeah. This pandemic hit and, we already had issues in healthcare, but all of those issues elevated. And then we also were faced with new ones. I mean, the first time ever that I can ever remember, let alone while I have been in this industry, practices closed and were forced to close. And, all of those investments in EHRs and other technologies really exposed a huge gap. Then, what to do next with this sort of immediate situation. It also further, I think, validated that while there's certainly a place for portals in certain care situations and maybe in certain specialties more so than others, that the reality is that the EHR portal also just did not turn out to be the Band-Aid or any kind of an answer to this immediate problem that came upon everybody in the delivery, on the delivery side of healthcare.
Right.
And I think it also has brought to light what we've all known, but it just hasn't been addressed, the fact that if you're in an area that doesn't have access to internet, which happens to be about 30% of the population, then you don't even have a portal. You don't have a portal or a prayer. Is that a song? No, that's.
Yeah, absolutely.
It should be.
Yeah, I actually think too, one of the things that was exposed to us as I was constantly challenged, because a lot of folks did not in the past, when I've described patients as customers. I think that's another thing that really happened during COVID. We actually very much were exposed to the idea that these are customers as well. It's not just a patient, but it's also someone who has an expectation of delivering a product in a way in which they want it delivered. And be it out of fear, be it out of necessity, be it out of state mandates, whatever the case may be, all of a sudden it became sort of interesting that these actually are customers. These people actually do have an expectation of how we're going to provide our product to them. So it was a little bit of an eye-opening experience on that as well. And to your point is also is, I think a lot of us had this thought process of, I have an EHR, so I should be good on all my technology needs. And I agree with that as well. It's one of those things, if you think about it differently, in one of my roles here is to kind of challenge your thinking on other than just healthcare space, is all of a sudden Taco Bell had to figure out, all right, well, how am I getting this tacos to people who are not leaving their house? And it does seem like a simplistic comparison, but it is a valid comparison, because all of a sudden you have to figure out, how do I maintain my business throughout this process? And whatever I do, is this going to be something that I can either undo or tweak or do better? So I think that's actually something also that actually came about with a lot of this surprise.
I would agree. I think that, I mean, in this crisis, certainly things like Netflix usage and memberships went up tremendously. Amazon went crazy with everybody, wanting contactless services, in addition to getting Taco Bell delivered, of course, a necessity.
Yeah.
How could you survive without?
Right.
But we've already experienced what that convenience feels like. And this pandemic and this crisis, and 7 months ago, completely, knocked healthcare on its head and said, you immediately have to figure something out differently. We all know how our space adopts technology, slow.
Right.
And so for lots of great reasons, obviously, we're very evidence-based, we're very conservative, and that's the nature of our industry. But this would be a great example where we just don't have the time to actually take 10 years to prove to ourselves that treating patients where they live and reducing as much risk as possible as far as exposure and other issues that come when you travel unnecessarily, that literally it's just hit us smack in the face. And so
I think I think the challenges that you highlighted here too, and this is, I mentioned earlier, one of my favorite things to do is actually strategic planning with practices, and in a SWOT analysis, looking at opportunities and threats. Looking at this as a threat is probably a mistake. One of the things that I see in COVID that actually it forced us onto a spectrum of competition that I think would have very likely not snuck up on us, but eaten our lunch. And what I mean by that is, you have the advent of teledoc, you have the advent of health systems investing very heavily in the telehealth space and just slowly, quietly pulling away our patients. And one of the things that COVID forced us to do is very rapidly get into this space and understand it. And now at this point, we should actually take that, what was a threat, turn into an opportunity and begin to facilitate that. And how do we actually deliver something to hold on to our patients in a way that we weren't necessarily expecting to have to hold on to them, but to hold on to them.
Yeah, completely agree that I believe that the kind of surge services of a Teladoc, American Well, those models will reduce the need for will reduce significantly, because this whole situation has proven to our provider community that with the right tools, they can support many care models, which I want to talk about here in a couple of minutes. But interestingly enough, I'd also say that, part of kind of pulling together some of these elements, through my conversations throughout the last 7 months, for sure, that's been interesting to hear. You just don't always think about is the dependency around technology and connection with patients around the four walls, down to the phone. But also there are a lot of EHRs, whether it's by permission decisions, for a facility, or just technological limitations, that not all staff members can get into a patient's record from home or outside of the physical four walls.
Right.
And if all you have is a phone for your patients to get to you and find out, should I come in? Am I sick? I mean, the CDC immediately told everybody to call your doctor if you think you're sick. Don't go to the emergency room. Don't go into their office. Call. So now, what was everybody supposed to do with that? If, phone volume has always been a huge challenge anyway in any practice, in any delivery organization. It's incredibly inefficient. But it just elevated again a huge problem, especially when a lot of staff, went home and some doors closed altogether. It created a logjam. Again, patients started going other places. Some practices lost their patients. And so again, it's looking at, we all made assumptions around our technologies, our major investments in EHRs, and we've just discovered that we still have gaps, especially with where we're going today, and treating the patients where they live.
Right.
And we know patients live where? They live on social media, they live on their phone.
Right.
And even more specifically, they live on text. We all do. I mean, you can.
No, I think, and that actually, kind of to your point, ironically, right before COVID, sort of the big thing struck us all, I guess, around February, March timeframe, particularly in the South where I am, I'll say that. Ironically, I did a strategic planning session with one of my clients, a dermatology group, in January of 2020. And what I had done was something very simplistic, and I've mentioned Teladoc because they're probably the premier, national, there's other ones, American Well, et cetera. But what I did was I actually took the dermatology group's ITIN codes, compared what you just mentioned, the advertisement of Teladoc, of everything that they can do, acne, et cetera, et cetera, et cetera. And it actually turned out that 17%, pre-COVID, 17% of everything the practice did, Teladoc could do and was advertising for it. And it begins interesting. I mean, you start thinking about that, and this was pre-COVID. So now that you actually talk about COVID and where so much more was forced, can you get that back? And that's really kind of the challenge a little bit too. One of these challenges here, the high number of cancellations and no-shows, you still have a higher level of fear factor. It doesn't matter what you think. It really doesn't. It doesn't matter what political spectrum you're on. It doesn't matter what you think about face masks. It doesn't matter what you think about, did men actually walk on the moon? It doesn't matter. If your patient actually is fearful and does not want to come into the office, you have to figure out, how do I get to you? It is now incumbent upon you as a business, on a business leader. How do I get to you? How do I actually facilitate this? I did I guess we called it COVID-4. I don't really know what we called it, but I did another one where I was a panelist. And one of the questions that actually came up was, what do I do to get my patients back? And the fascinating point of this is what you just said. You combine social media, you combine telehealth, you combine the fact that people have fear, and you solicit them. You actually send them an email, send them a text, let them know, hey, this is an option. I would love to see you. I miss you. I care about you. So that's really the value play that we have in particularly independent space, is that we have a higher touch ratio. We have a higher relationship ratio than these others. The other world is this production world. You know, it's just production. That's what I want to do. Teledoc is production. I'm not looking for a relationship. I'm looking for production. So I think, and I think that's where you actually combine this with technology, telehealth technology, and the relationships you have, and embrace that.
I agree. When I want to share this other view, which I find interesting, sort of the kind of continuation of that thought process. So I would say don't email them because nobody reads email, but but certainly text them, certainly send them a Facebook, Messenger message, find platforms that do that. Because that's how people want to be communicated with. 99.1% of all text messages are read. And frankly, I haven't met a millennial that when they see that red button show up on Messenger doesn't open it up.
Yeah.
But I then, if you kind of slice it a different way, like so many people have been watching where these telehealth visits are, what specialties are really leveraging them in this particular time in our lives. And this is just a snapshot, but it actually is pretty representative over several months. But interestingly enough, of course, psychiatry or behavioral health, is really leveraging this service. Whereas previous to COVID, there were significant limitations from a reimbursement perspective. Using virtual care platform technologies. It was very traditional as it related to reimbursement. But also, if you think about people that need outreach, that are having psychiatric or mental health issues,
right?
You have to also think about what's going to be the way that is going to be most successful to engage with patients and people who are in this particular place. And something like texting, I think, is the only way to start because it's sort of anonymous, right? You can do it, in your own time, in your own way. And, it's sort of passive, right? So I think that this is telling us, and I've said this many times on lots of other panels and interviews, that I think behavioral health is 2021's new crisis.
Yeah, I don't disagree. To follow your thought on this, I'll give you guys a little bit I'm doing another presentation tomorrow actually on AI, and you and I talked about this a little bit. And one of the most fascinating elements of AI right now is actually the use of AI in psychiatry, artificial intelligence in psychiatry, but also telemedicine. And the reason it's kind of interesting that psychology. We are looking at psychology of psychiatry. So the psychology of this is actually that many people feel a reduced barrier to having a more honest conversation about their mental health needs in this environment because they don't feel like they're talking to a human necessarily. It's it actually removes the barrier, which is sort of fascinating. The use of artificial intelligence also is very active in the psychiatry space for something that humans have trouble doing. Particularly, I can say this as a man because we always have trouble listening to anybody. We have that difficulty. The words like when a lady says fine or sure, like they should be red flags to every normal man in America, but apparently it's not for us. But in the world of psychiatry, the article that I was reading was actually talking about little tics, voice inflection, just simple movements that actually were indicators of some mental health issues with regards to depression, et cetera. So it's sort of fascinating to begin thinking the use of this and actually how it can actually benefit us as we progress forward. And I'll also say it's sort of ironic because yesterday I mentioned I turned 50. I had a physical the other day. I was there for 2 hours and I had human intervention a total of 10 minutes. And I was actually trying to figure out, why in the hell am I here? Could we have not just had to, like you just asked me a bunch of questions that you could have probably done. Granted, the guy just like put that, thing on my chest, and I appreciate it. I really do. Don't get me wrong. But you do begin to start thinking a little differently, particularly given COVID, and particularly what's happened is how much of this are we unaccepting because we just don't want to change, like what you were saying before, like we just don't want to change. You know, you and I had this conversation about other industries, and we are lagging. We are lagging.
Yes.
It used to be that we were in the same boat as banking.
Yes.
They have now surpassed us. Apparently, you don't even need to go to the bank ever again. I can just, you know, touch my phone to your phone, and all of a sudden you've got all of my money.
Okay.
You know, where we are still struggling. We're still struggling in this space. And I do think that when you start looking at these specialties, I've had this conversation with a group of rheumatology managers when I was doing my last presentation, and it was interesting because they are still very adamant that we've got to touch you. And it's just sort of an interesting question, because I've had numerous questions with physicians offline, and I've asked them, like, can you help your family members who are in a different state just by simply talking on the phone with them? And the answer usually is yes.
Yes.
Then then my question is, so who are you not giving good care to, your family members or your patients? I'm confused.
Right.
So,
and if you're like me, if I'm waiting more than 30 minutes, I'm leaving. And so then I'm not getting any care. And, you know, that's where we see progression.
I was that close. I was really, really, really close. If I had not had good Wi-Fi, I probably would have left. Because I had not read the paper yet that day. So I had to get 2 hours to read the paper, catch up.
It truly is like the eighth wonder of the world as to why, when you make an appointment, you usually know why you're coming in advance. And so does, you know, the space. Why sometimes there are always uncertainties in healthcare, of course, but I once had a provider, a specialist that and unfortunately I lived in a town that had a shortage of specialists, but I would wait every time no less than 2 hours. And unfortunately I just had no choice. But it was like, why is this? It's capacity and demand. You know how many rooms you have, how long you're going to see your average patient. Like, how is this happening every time?
Yeah, I think also too, I'm going to highlight something you mentioned earlier. I think one of the challenges that healthcare space has, particularly physician groups, and I want to really kind of hit this home for the audience, because this is what I hear from a lot of our clients. And I told you that we have numerous RCM clients, and I have a lot of physicians who keep asking me, is a telemedicine reimbursement still the same as an office visit? And I want to challenge that thinking a little bit, okay? Because all of that is built on, we needed to push you into this space. That was why everyone said, look, we're going to pay it the same way because we're going to push you into space. I want you guys to think about the stimulus program with the $21.3 billion or whatever for EHR. It was the same thing. It was an incentive program, get you into the space, and then I'm going to pull it back. I want you to start thinking differently about this. Your delivery of a telemedicine visit is not the same as your office visit, okay? It is not. You do not have the bricks and mortars. You do not have the parking places. You do not have the seats in your waiting room. You do not have someone actually physically taking someone to the back space. You have got to look at these in a profitability sector mentality. You cannot look at these the same way.
You don't have PPE.
Right.
I mean, look at the added cost of PPE because of additional protections and sanitation and, you know, things that have to occur now.
It really hit me. It really hit me when I started thinking about restaurants and actually the reduction of the wait staff. I don't know how many of you actually have traveled back out now and gone to a restaurant, but if I have to scan one more QR code for a menu, like, I'm going to jump out of my skin. But it's an interesting element because now it's reduced the cost. We went to one restaurant where actually we had to order on an app on our phone, and the waiter and waitress never came to the table except to deliver the food. Now you start thinking about from a labor force standpoint, and also in our world, same thing. Like, what is this that actually am I reducing from a labor standpoint? So it might be that my telemedicine visits are not paid at the same level as a 99213 or whatever the case would be. But what you should be looking at is unit profitability. That's what you should be looking at and exploring this. And it should go into your thought process for the future with regards to your practice expansion, recruitment, et cetera. So I do want to sort of reinforce that to the audience to make sure you're looking at it the right way.
I love that. And I think that is because you can also see more patients in a virtual setting as well, which, you know, is another piece of that puzzle as it relates to care and margin and you know, total unit costs, as you put it.
Right.
I think I was having a conversation with a very large orthopedic group the other day. They've got over 50 physicians, and they are in BPCI, and they've got commercial bundles, and they're in a really desperate situation, not only because they've got a lot of competition, they're private, not part of a health system, but they're very focused around how to keep their patients out of the ED and urgent care clinics. And I think that's all part of the equation, as our nation is moving more and more into value-based care contracts and risk programs. And I bring up this slide because it's a snapshot from April, but sort of when we were on the rise of the peak of the crisis, if you will. But what I found most interesting is not that we're using telehealth and virtual care for COVID, makes sense, but that our delivery organization industry was quickly understanding how to leverage that approach for other reasons, right, for chronic conditions. I mean, the delay of care situation that we don't even know what that's going to mean to us until later this year and next year, I believe, is again sort of it's the unknown right now. But in looking at this, it tells a great story to me, that there was immediate understanding that, wow, I need to use it for this urgent situation, but I can also use it for other forms of care because I want to keep my patients out of my waiting room if I don't need to have them come in. And then with CMS leading the way and telling us that they expect over 20% of clinical encounters to be virtual starting next year, sort of surprising, but also good to hear. And obviously we continue to see the physician fee schedule comments coming in, and certainly MGMA has also commented as well, which is terrific. And so that, to your point, Cameron, that people are opening their mind around what it means to deliver care virtually, to treat patients where they live, so that we can keep patients from getting sicker, hopefully get them more well, right, get more people involved in care that are not receiving any care at all, and then lastly, make it safer. And right, that's how, hopefully that is how everybody's starting to think about the future of where we're at, and that the unit economics can't be so singular focused, or look at it from a historical view. I think your point is super valid. And
also, we also, I'm gonna to the audience, because I know many of you are sitting in your chairs and you're thinking, like, how does this guy know what I'm thinking right now? Like,
because you're wrong.
Many of you are sitting there thinking that what we used to say, the barrier for anything that we wanted to do technologically space, it doesn't matter what it is, credit card on file, having someone do something electronically, having someone actually whatever, was always because I can't get my Medicare patients to do that. I am here to tell all of you that I watched my mother, I watched my mom use an iPhone for a neurology telehealth visit. I watched it. I witnessed it. I love my mother tremendously. Yes. And before that, she was someone who was completely unwilling to do this. Now, what COVID actually forced is a little bit of that patient population that we used to get to hide behind, claiming that this is the group that's really holding me back. If it wasn't for this group, I would do all of this stuff. Mm-hmm. But now this group is willing to do it. To your point, this group is willing to do it. So the decision that many of us face now is, do we want to go back and do it the other way, because we really are saying that we want to do it this way because of the compensation programs that we have set up in our practices? That's really why we want to do it. Or do we want to actually keep this in motion and engage both? That's really what we should be going after. Mm-hmm. And I mentioned earlier, and I want the group to think about this too. I wish I could see you, because I would actually tell you all to raise your hands. How many of you actually have used, for the first time ever, DoorDash or Grubhub during this time frame? I knew they existed, but I never used them. And I like to think of myself a little outside the box kind of guy. Never used it. Wasn't going to. I didn't need to. I can just drive over there and pick it up, right? Well,
Go ahead and chat it in, folks. Go ahead and let Cam know
Yeah.
who's used one of those too.
Right. And so if you have a supposition that you use this, don't you think you would like to continue to use this? And that's really kind of our point today, is that this is not going to go away. So start embracing it and figure out, how else can I do this? That's really what this whole concept is exposing us to, is what can I do now to utilize this as more effectively in delivering the care to our patient, both the way they want it and what's in our best interest as well.
Yeah. And, you know, kind of on that point, and it's not just for, you know, the teledoc-like services, right? It's not for the eye infection, you know, or the acne or what have you. It, you know, we really, you know, at Rhinogram, certainly, you know, me and my team, we have a lot of conversations with, you know, different executives and leaders in healthcare across the spectrum of care. And I love the fact that, you know, that all of y'all and our space is actually looking at this topic, this notion of virtual care across, you know, multiple care models. It's not just keeping your patient well, your annual visits, your sort of low acuity issues. We have a very large piece of our population with comorbidities. And then you couple that with a big percentage of those patients also happen to be sitting in rural settings, underserved populations. And so we have a potentially a technology gap.
Right.
Unless you're using Rhinogram. But say generally speaking, with the technology that exists today, we have a gap and we have a challenge, and we cannot wait. I'm so glad that the government is looking at how to lay more dark fiber down and get people connected, certainly for education and many other reasons that is needed. So keep doing that. But in the meantime, we need to get care to more people. And we need our healthcare leaders and physicians and clinicians to be thinking across more care types that are needed. I mean, think about infusion.
Yeah.
Why can't that happen at home? You know, it's, you know, there's, you know, home care has been sort of on the fringe for a little while. And I think that, you know, we're going to see a whole, you know, new kind of evolution and revolution, sort of like the Uber, you know, revolution.
Right.
You know, taxis were not new. You know, ordering somebody, you know, stranger to drive you around from one destination to another, that's not new. But how you found, you know, that car based on your own convenience elements is what changed that game. And I think that that's, I mean, it's been said many times, the Uber of healthcare, but really thinking about more specifically, what does that mean?
Absolutely. And to kind of go along with that, so Uber actually asked people who had cars, do you want to work for us and do it this way in this disruptive environment? Yes, when I had my physical, one of the things that we're not talking about that also goes along with telehealth is actually your own personal analytics. And if you'll see, I have a Fitbit on. Mm-hmm. And so yesterday when the medical assistant took my beats per minute, I already knew the answer. She said, your beats per minute are 58. I'm like, well, 57, but who's counting, right? But my point is actually with the intrusion of these companies as well, particularly in Amazon moving into the space with Halo, you have Fitbit actually acquired by Google. You're seeing more and more analytics. The most recent introduction by Halo and by Sense, which is a Fitbit product, both of them are using analytics to identify stress, to actually deal with oxygenation levels within the individual, also to help with temperature monitoring on a daily basis with regards to potential COVID issues. You combine this with telemedicine, and actually what you're starting to see is this disruptor using other tools all around us to do exactly what Kathy is describing, which is let's actually figure out a new way of the continuum of care to help the patients where they need it most, which, like she's saying, most of the time is at home. That's where it is. And particularly when you start moving more and more down the spectrum of ACOs, accountable care organizations, the premise that we all have that's a problem is that we're accountable, but how does the patient become accountable? And you're starting to see more and more of that with these types of self-induced analytics coming into the picture. So now all of a sudden I got some higher level accountability in this, in combination with telehealth. You can actually see the movement of, okay, I got to get the people down the continuum of care. So you begin to see that. And that's what's actually, it is sort of fun. It's scary because all of us own banks that have bricks and mortars, and we have, we only know how to do it this one way. And the whole point of today is to step back and figure out, okay, well, how can I live in this new space? What can I do to facilitate this consumer activity that is right now on a continuum that I want to be on? How do I engage in it?
Yeah, I couldn't agree more. And, as there are technologies today and there are new technologies being developed, that will continue, I think, to service this more consumer mindset, more AI, more, passive monitoring that can intelligently understand and provide insight to your provider. Yeah. I think about, so many people I know personally and also spending so much time in clinics, patients that have a progressed condition, and you ask them, how long have you felt this way? And many times it's a long time. And if you kind of back into that, so, how did we get here? What's behind that? Oftentimes it's convenience, access, people don't want to sit in a waiting room, can't take the time off. If you work in a factory here in Chattanooga, we've got Volkswagen here. It's a huge factory. It's awesome. Employs thousands of people. But the way it works is most folks on the floor have 12-hour shifts. And when they take their 15-minute break, they're not allowed to talk on the phone. They can only text. And if your 12-hour shift is during the day, like 8 to 5 hours, how will you ever talk to a doctor? How would you ever make an appointment if you can't, and if you don't have another way to get connected and stay connected? And usually it's never a one conversation to get something scheduled or to get something refilled or prescribed, those kinds of things. But if we do think bigger, broader, differently, and change our approach to the model and make sure that we are using the best technologies. I mean, I will say, we know lots of folks, went to drastic measures to find a way to better connect with their patients remotely. So, using Zoom, which, or Microsoft Teams or things of that nature. And somebody, the hospital CEO said it best to me when he said, I'm buying a virtual care platform because we use Zoom and it was not designed for the purpose of delivering care. And I loved that statement. I use it too, but I give him all the credit because it is in healthcare, especially, you really do have to use a tool that's designed to help you deliver care. Trying to get Zoom, it's a video and it works great for meetings. For this virtual session, it's awesome.
Right.
It serves a purpose, but it was built for this.
Right.
But it was not built to diagnose, triage, monitor, engage, educate, all the things that really make up, kind of the whole picture, what, I like to call the journey, if you will.
Yeah, you back up real quick. I just want to
Sure.
make one comment about this, the virtual spectrum that you have here. I want to mention something else to the audience, and my hope is that many of you are reading and keeping kind of up on the bigger perspective of what's happening in healthcare. But I'm going to mention two other organizations that you should take note of. And one of them is Walgreens. Walgreens' recent joint venture with Village MD, 700 clinics across the country. I want you to make note of that, because when you start looking at some of these pieces down here and what Walgreens intends on doing, the other one is actually Walmart. And I know everybody's like, oh, Walmart, it's not real. Walmart for the last 2 years has quietly been actually creating a whole new strategic plan. And here's what's different about what Walmart's doing this time. What they're doing this time, they actually asked patients what they needed. Novel concept, I know, novel concept. But if you haven't been watching this, Walmart intends on, and the very first location is already open. A friend of mine happens to live in the town where it opens in Georgia. The new clinics are $40 for a primary care visit. $40. There's no copay. There's no anything else. It's $40. Now, if you think about this, Walmart has the infrastructure to do this on a larger scale, and it does not need bricks and mortars. You need to start thinking about this. We're going to have more people going after our patient population than just the teledocs, than just the local health system. That's not the case anymore. When I was younger, Cleveland Clinic stayed in their own backyard. They now own facilities down in Florida. You know, we have to not keep ourselves, again, myopically placed within the four walls of our own communities. That's not who is going after our patients. Everyone is. And these companies now, if you start thinking about the CVS and Aetna merger, you start looking at Optum being the largest employer of physicians in the country, is owned by United Healthcare. You have to start thinking this. This has to sit within your strategic planning thought process when you're looking at this technology and going forward. And again, doing something for your patients proactively. All right, sorry.
No, actually, that is such a great point. Everybody is your competition, essentially. And, you know, even
Yes.
as we look at the relaxation of state lines and licensure expectations and requirements, and then on the flip side of that, you look at people moving out of urban areas because they, you know, the new working setting is, you know, at home.
Yeah.
And for a lot of companies, it's permanently changing to that. And so people are moving into lower cost areas of the country. And some people are even leaving, say, the
States.
Yep.
Yeah,
Yep.
we're actually seeing that. There's actually real estate movement in North Carolina. So where we live, North Carolina is apparently like one of the most perfect places to live on the planet, which, you know, doesn't surprise me. But we have a lot of growth coming from a lot from the north. We have 4 seasons, so it's an ideal location. So we're actually seeing a lot of movement of people moving here, living permanently, but working still for the corporations in San Francisco, California, whatever. It doesn't really matter. We're seeing that. And I think that to your point, is a very true statement. And again, will facilitate the use of technology to maintain that healthcare. And also, to your point, I've actually said this before a lot of times, you know, if you live in Iowa and you get in a car accident in Texas, my assumption is you do not actually stop anybody from helping you because they don't have a license to practice medicine in Iowa. My suspicion is that you're probably okay with it. We all know that it's really, we've designed the system such that it's a barrier. And that barrier is going to break down. It's going to continue to be forced to break down because it has to. The VA already has broken it down. So physicians' licensure for the VA system, it doesn't matter what state you're in. It just works across the United States. It'll eventually happen the same way, I think, in medicine.
Yes, it needs to happen sooner or later. And since you're plugging North Carolina, I'm going to tell you that Tennessee is also one of those fabulous places to live. And we're getting a lot of folks from the Northeast, especially New York, moving to Nashville. And so therefore, Nashvillians are moving to Chattanooga because we're basically a suburb of Nashville.
Well, we have a town called Cary that when I was a kid was 5,000 growing up. Cary actually stands for Containment Area of Relocated Yankees. That's the in-state joke about it, but it's kind of ironic. It's now the 7th largest city in North Carolina, and it's primarily the influx was from New York, New Jersey, Wisconsin, Michigan area. So there was a lot of growth in that due to that. So, you know, it is something that, you know, to recognize.
Yes. Everything's better in the South.
That's right.
And I grew up in California, so I can attest to that. So sort of to kind of wrap this up and where, you know, you had referenced sort of in the beginning about your own experience as you've hit middle age now, and also as I was talking about waiting in the waiting room and how much of, you know, the patient workflow, if you will, or the journey, you know, the average encounter journey is about 100 minutes. And that is sort of this journey. But only 22 of those minutes is actually the clinical encounter on average. You know, obviously certain things. Yeah, so what's happening outside of those 22 minutes? It's paperwork, it's waiting, checking in, it's updating records, and then it may be part of that intake process, updating medication records and things like that. And then it's after, it's booking your next appointment, getting discharge or post-procedural instructions, it's follow-up, it's questions, after-hour support, things like that. So when we are talking about this notion of virtual care, it isn't just, and this is what I want to really stress, is think past the video visit. And, thanks to Teledocs and, others, who started this, over a decade ago, through the health plan approach, we've sort of educated people that that's what telemedicine is, or virtual care is, if it's a video encounter. Ann Mont Johnson, who's the president of the ATA, wrote a fantastic piece last year before COVID, specifically on the 7 myths of telemedicine, and one of them is that it's video only. And I love that, because again, when you think about the diversity of our patient population, whether it's lack of internet access or an aversion to care for whatever reason, or their senior population don't want to drive at night, there are all sorts of different elements that come into play here, that we just have to leverage technology. But it's more than just a video visit, because again, if you think about video as your telehealth solution or method or design, what does it take in order to get to that? It's still the phone calls, and maybe it's emailing, or it's a whole bunch of things that are still super inefficient and create a bunch of barriers to ever get to that clinical consult that you need.
Right.
And so, we really want everybody to be thinking differently, as you nicely said, Cam, at the beginning and throughout here. But why does so much of that journey have to take place, sitting in, a physical facility? Yeah,
it doesn't. I mean, it's, I'll use the chats. We had several chats. A lot of folks talked about that they didn't necessarily use DoorDash or Grubhub or whatever, but a lot of people mentioned online groceries. And that's actually a fascinating concept, because using that as an analogy to what you're doing here on the patient journey is telemedicine visit is basically like you picking the groceries up. That's it.
That's right.
But there's all this other stuff that actually goes into it. It goes into, you have to go online, you have to order the groceries. Somebody there at the grocery store has got to pick them all up, put them in a cart. You and I all walk through and watch these people, because these people didn't used to exist. But now when I go to the grocery store, they're in my way. So you start looking at that as the telemedicine visit is not just online groceries. It's everything else that actually goes into it. And how do you use that to your advantage? Because a lot of you who actually are doing online groceries, for example, now, you're sitting there going, do I ever really want to go back to the grocery store? Yeah. I know there are people who are sitting here right now thinking that exact thought. And particularly if you can deliver me beer, like I may never ever leave my house again. There's a very distinct possibility. And so I've been thinking about this also. Another interesting approach, and I want to mention this too about the telemedicine visit, is you think you're sort of done. Netflix is a great example of someone who probably realizes we're not done. We can't be done, because what happened with Netflix is you guys actually started running out of things to watch on Netflix. And Netflix was like, I don't know what to do now. And everybody else started figuring it out. So that's what's happening in your space. You need to go after it. You need to go after those patients. You need to realize that this is not done. This is something that's going to constantly change and evolve and shift and change. You have to be malleable to do it with it. That's what you're going to have to be responsible for. Now, does it suck to have to do that? Yes. But that's the joy of owning a business. That's the joy of actually running a business. I know that because I've run a business for a long, long time. And it is the challenge that we face, is how do I constantly reinvent myself, constantly redo this for the customer's needs. So this will be a lot of fun. I mean, it's going to be challenging. I mean, it's not going to be easy, but it's also one thing I did want to mention. I thought that Rhinogram would appreciate this as well. I read an article recently about the competition between EHR vendors and third-party organizations. And I thought it was interesting, because when I read the article, I thought that's interesting, because they're not also talking about the other competition that's out there. which is the ones who have their own platform who are competing for your patients one-off. For some of you, this might have not been the case, but I will tell you, I want many of you to think about how many of you are approached by your local health system to say, would you like to use our telemedicine platform free during this pandemic? Would you like to do that? Or do they just actually go after your patients? Those are the kind of questions you need to be starting to think about in your head. Is nobody was trying to help me out on this. I have to solve this myself. So as you're looking through this journey, as you're looking for this patient solution, make sure these solutions are for you as well. So
virtualize as much as you can.
Absolutely.
It's a great place to start as technology continues to improve and more advances will come.
Oh yeah, because artificial intelligence, I'm telling you guys, I'm doing a presentation tomorrow. It's right around the corner. You think telehealth is hard? You wait to see AI.
Yes. So I think we're just up to time. How are we doing, Jean?
I have a couple of questions that have come in, and you're not going to see them in the chat, so I'm going to try to just, Cam, you and I talked that this would challenge some folks, and there's still that, by the chat, you're seeing that DoorDash and some of those other things aren't as available here in Iowa as they may be in some of the big cities. But what about the human touch and the hands-on and, the diminished possibility of quality, not to mention increasing unemployment by reducing staff? Can you speak to that?
You want me to go first or you want to go first, Kathy? I can go first.
Good.
Yeah. This is going to be harsh. All right. One of the things I did during COVID, because I had a lot of free time on my hands, so I couldn't go anywhere. I love to travel and I wasn't allowed to travel anywhere. So I took an Enneagram test, and it turns out I'm a type 8. And one of the things that signifies a type 8 is you can't be mad at the truth. All right. So I'm getting ready to say something that's going to make some people mad, and I don't mean to, but it's going to. The world doesn't care about some of that. And I'm sorry. Because what you're describing, the very first part of your question, Jean, is interesting because the human touch may be important to you. That's the caveat of this. Some of your patients aren't going to care about the human touch, and some of your patients are going to care about the human touch. And that's okay. That's where the system that you need to design actually meets both needs. And I'm going to use an example here of, we used to have these things called airlines. I don't know if y'all remember, but we used to have things called airlines. But Southwest actually had multiple ways in which you could actually get on the plane. You could actually print a piece of paper and have that scanned, or you could use your phone and have that scanned. You could do it yourself, or you could have a gate attendant do it. It didn't really matter. But you had multiple methodologies of getting on there, and that was actually to meet all the needs of the customer. Same thing applies in healthcare. Make sure you're not designing a system for one patient population, okay? Think about what I said, okay? And as a man, I am, first of all, impressed I even went and got healthcare, because we typically don't until we have some sort of face gash or something. That's about the only way I'm gonna get healthcare. But when I went, I sat there and thought, I don't need you touching me. I don't need this. This is not what I want. So as you're designing the system, make sure you're not designing a system for you. This is one of the questions I used to challenge groups on is, whose schedule is it? Is it your schedule, or is it the patient's schedule? And if you stop just for a moment and just kind of go, that blows your mind away a little bit, because if it's the patient's schedule, then I don't sit around for 2 hours. If it's the practice's schedule, if it's the physician's schedule, then that's not how that ends up happening sometimes. So make sure that that's the case. Now, the second case about unemployment, I do think that's a valid concern. And in an economic society, we are concerned about that. But you got to remember that everybody also is hyper-focused on the cost of delivering care. Everyone is hyper-focused on that. Particularly as the boomers loom out there, we don't have a really good solution for actually how we're going to deliver care across the board on this. To the point that we described on psychiatry, mental health is one of the most expensive elements of healthcare in our country. It is incredibly expensive, and it actually drives all kinds of problems within the healthcare system, not just in mental health itself, but in everything else that we do. So actually solving these problems end up helping us. It's just hard to visualize that in our own little microcosm. That's the problem that we have, that each one of us, particularly in this group, there are people here who are in different specialties, and we tend to think just in our specialties, but the rest of the world is looking at healthcare in an aggregate fashion. And that's really the challenge that we face when we're running our own businesses. It's hard for us to step back and look at that. And that's how the world is looking at it, unfortunately or fortunately. It really kind of depends. So that's my perception on this.
Kathy,
I
do
was
you have a
just going to
response?
say that, I mean, I can remember back, I built the very first wrist pack system in the market a long time ago. And we started adding basically AI or CAD tools to do, computer aided diagnostics.
Sure.
And there were similar statements at the time. And this was again, like 25 years ago, but it was, a computer is going to take my job, I'm not going to be needed, this sort of thing. And I think it's part of evolution as well.
Yes.
And so, we are intelligent beings. And so as, kind of more, say monotonous minutia, lower level things like pushing paper around and calling patients all day long, as those things go away, it allows the staff that we have to turn to higher value and more difficult, roles, that would require, maybe also would garner more pay. The reality is that we have a shortage of clinicians in the US, and what everybody is saying is that the new primary care doctor is going to be a nurse, not because doctors are not important, it's because we already had a shortage before COVID. We have a bigger shortage now because of practices that will not reopen, are not reopening, specialists that have shut down, about 40% so far, unsure whether or not they're going to reopen. So my belief, and just looking at healthcare over the last 2.5 decades, that as new technologies come in, it is a common concern. And yes, certain jobs do go away. I mean, I remember implementing systems when, we pulled charts and pushed, and there were people that pushed, carts around with charts, for rounding, and, that role is gone. But, does that mean that our unemployment, went through the roof? No, it means that those people were trained to do other things and filled other gaps, in healthcare. So that's my 2 cents on it.
I agree.
Thank you. And we have another question that is different. And then, so it's kind of a two-part question. Wondering if you have insight as to how CMS is going to handle the originating site restrictions outside of the PHE, and should we expect changes with the final rule?
I'll let you go first this time.
I think it's going to be really hard to walk that back. I mean, I just, I think there'll be some attempts to do so, but I just think that, I mean, I hate to be super cliche here, but genie's out of the bottle, toothpaste out of the tube. How do you take that sort of freedom and extension? How do you walk it back when there was clearly a justified reason to open up those accommodations and that line of thinking? So if for some reason they pull that back in, I just don't think it'll last.
I don't disagree. I mean, I think you can actually even look at the accelerated loan payment program that rolled out very quickly and very quickly stopped on April 26th. And now CMS is struggling to get that money back. I'm with you. I think it's going to be very difficult. I think politics of it is what makes it tough. Whenever you actually introduce an entitlement in whatever sector, it doesn't matter if it's an entitlement, quote, to a certain business sector or to patient population, you're not getting it back. It's hard. I agree with you 1,000%.
Yep.
We have just a couple more minutes, but there's a follow-up question. There are times that a physical exam is truly needed. Do you see many practices offering or selling the biologic tools to help them with the exam at home?
You can go first. There's different sectors. I mean, it depends on which specialty. Are we talking about, is there any clarity on this? Are we talking about primary care specifically? Are we talking about a certain specialty? Are we talking about, do you know, Jean?
I think primary care.
Okay.
Kathy,
I'll let you go first and I can augment.
Yeah, I think that, so there's certainly a lot of activity on the commercial side to try to figure out that sort of package, let's just say, of combining wearables or biosensor technology and care platforms. What I would tell you, and certainly what we are working on right now, is leveraging kind of the next stage of technology. So there are really interesting AI tools and approaches that actually can collect most of the major vitals that you need without a bunch of clip-on, add-on, stick-on devices. So certainly, and don't get me wrong, of course, there are absolutely many types of clinical consultations and encounters that need to be in person, for sure. This topic is about when you don't need to, which there is also a lot of those. Right. And how do you make, when you do need to be in office, how do you make that time the most efficient, and so that you can see more higher acuity patients and more complex cases when you're in the office. But I do think we'll see more, things in offices, and that will serve a purpose for a short period of time. But what we're certainly experiencing on the technology vendor side is the advances are happening way faster than ever before. And so, we're certainly going to kind of sort of scoot over the stick on, stick in, press here sort of things, and really leverage kind of the next level of technology.
I think you'll see that. I think also to the question here, I'll kind of put it back to whoever asked the question, particularly in the primary care space. I would argue that in primary care, one of your goals in primary care is actually to see the patient regularly. It's actually one of the objectives of primary care is I need a regular intervention with you. And one of the problems that we usually have is the obstacles to intervention, like me actually physically making the effort to come see you versus, can I just click a button and see you? Because I can tell you that I'm a little bit more interested in that. And from a primary care space, when I was sitting in the, and I actually went to see a doctor at Duke University, but I went to see my primary care doctor as part of Duke. And one of the things that kept popping up on the screen as I was waiting during my visit was, make sure your doctor gets your weight. Make sure your doctor gets your weight. And I sort of thought about that. I was like, you know what? Why can't I just shoot that to you every day? I can do it on my device every day. I know my weight every day. I actually have an endocrine practice also, that one of the number one responsibilities of both the endocrinologists is actually monitoring patient wearables. I mean, that's one of their number one tasks, is just monitoring what they're doing, and like their blood level, everything. And it's not the patients are coming in the office. So you want to kind of back this up again. Back this up is, how do you really want to deliver care? If you want to engage the patient more regularly, this might be one of the things. Because I asked the doctor, I said, when was the last time I came to see you? He's like, I don't know. Which I thought was like sort of fascinating. He's like, why don't you know? You should know. Like, shouldn't you want to see me like every year? So I'll flip it back on its head a little bit. Is all we're suggesting is the possibility of another platform to keep that patient engaged on a more regular basis, which actually is a better thing for not only you, but also the patient.
Well, we are running a little bit over, but there's one more question, and if you can't answer it fairly quickly, then we'll ask you for your responses, and I'll post them to the event page. But the question is there a concern about the liability of virtual visits? For example, the provider could miss something since doesn't have any hands-on.
You want me to do it? You want to do it?
I don't know if I can do it quickly. I do hear this a lot. I'm going to try. I hear it a lot. And the universal response from other physician and physician leaders that also get this question is that you have to determine your approach to care for the situation that you're diagnosing or that you're dealing with, and that not all issues should and can be done and diagnosed and managed virtually, and that as a provider That's part of your expertise, is to determine how best to treat.
Yeah, and on the flip side is it, if it was the case that every time I showed up at the office, then nothing would be missed, we would have never had lawsuits before this. So
Also true.
it's been great. We've enjoyed it.
Yeah, thank you everyone for your time and questions, and obviously lots still to talk about here. So looking forward to the next one.
Nice job.
Sure. And Jean, you mentioned if there were any other questions, we can definitely get those out in writing and make sure that we get answers back. So thank you all for texting in those questions. Thank you, Batman and Robin, Kathy and Cameron, for the great presentation. And thank you, Rhinogram and MSOC Health.